When we talk about health and what generates health, you have to talk about the cell. Remember that when you put cells together, you get tissues. When you put tissues together, you get organs. When you put organs together, you have a body. So instead of treating the thyroid or the liver or the pancreas or the IBS or the IC or whatever it happens to be, you want to look down at the dysfunction in the cells.
Dr. Armine, welcome to today's episode of What About Rural Health, where we ask hard questions about how money moves, who gets funded, and who get left out. From policy to practice, we explore what rural health financing should look like for everyone.
I'm very happy to be here. I appreciate the opportunity to speak with you and your audience.
Thank you very much. My name is Chinasa Imo. Today's conversation, can holistic care make rural healthcare more affordable? We'll dive into how integrated care model could provide affordable care and address care fragmentation issues in rural communities. This is part of our ongoing series on rethinking rural health financing, both the investment and the opportunities therein. So, while I was preparing this episode, I had a conversation with a nurse friend who works in a small rural suburban area here in Illinois. She told me about her patient who is dealing with fatigue, joint pain, severe brain fog, and this has been going on since after the COVID pandemic. Well, that patient has seen multiple doctors, ran several tests, and had been prescribed medication that individually address some of her symptoms. But what this treatment is yet to do is answer the question, what is going on in her body? Yet the bill keep piling up, the traveling to the nearest health facility is adding up, and the patient is still searching for relief. This is a common
Well, this is
experience.
it's an interesting answer to that.
Yeah.
First off, the nurse practitioner, if I heard you correctly,
Yeah.
are some of the best practitioners you can possibly go to. Before I was a physician, I was a nurse. Before that, I was a paramedic.
Yeah.
And I can tell you that the closest you're going to get to true, I won't say integrative, I'll say general care, is with a nurse practitioner. Why is that important? You know, modern medicine has become extraordinarily specialized, okay, which has brought a lot of advances, but it's also fragmented the care.
Yeah.
So somebody with fatigue may see a rheumatologist, you know, maybe a gastroenterologist, because this fatigue is usually something else. They might see a neurologist if they're having mood problems. Each specialist is good in their field, but they don't look at the entire person the way a generalist or our old general practitioners, let's say 1970 and before, used to. Okay, those, you know, we always ruminate, we always hope for to get back the practitioner who knew you since you were a baby, knew your family. And by the way, that was valuable. Okay. Now, the other issue is the overdependence on testing. In other words, instead of what Sir William Osler, the founding father of Johns Hopkins, said, listen to your patient, he's telling you the diagnosis.
Yes.
Instead of doing that, we are now looking at evidence-based medicine, which means if the test doesn't show it, it doesn't exist. Nobody talks about the limitations of the testing. And if you sit down and listen to your patient and know how to know the clues, okay, so you said that this person had extreme fatigue. If I misspeak, correct me, okay? I don't want to exaggerate. I don't want to lead anybody down the garden path. All right. So if I say something that isn't exactly accurate, you say, oh, no, it wasn't this. You're not going to offend me. All right. But you mentioned that this happened post pandemic.
Yes.
Okay. Now, the studies that have come out and my particular practice, because I'm on the forefront of exactly this, is from the COVID vaccines or the COVID itself, which hurts the body through something called a spike protein. It's not important that you know exactly what the spike protein is, except those things occupy certain receptors and stay there
Mhm.
and interfere with certain critical body functions. So since the pandemic, we've been seeing an increase in fatigue, fibromyalgia, pulmonary problems, heart problems, cancer, infertility, and many other things, especially anything connected with chronic inflammation, which is almost everything you can think of, like autoimmune diseases, things like rheumatoid arthritis, Hashimoto's, and so forth. Why is that? Well, the spike protein affects mitochondrial function. Your mitochondria is what creates your energy.
My,
And
can you
mitochondria.
describe?
Yeah,
Okay.
that's like one of the big concentrations. And I'm going to explain that in a second. Okay, because it is really critical,
Yes.
especially since you tend to hear the term all the time. So let me take a few seconds to explain it so that we take the mystery away. Okay. It's
Yes.
not a lot of this stuff. If you understand the concept, you can understand it better than most doctors. Okay. So how does one figure out what the heck is wrong? It's taking a history. It's, listening to your patient is not only listening to their complaint, if you will, but accepting the complaint, never saying in your head that can't happen. I teach courses to other doctors, and there's only one phrase. If I hear it, you'll get literally kicked out. And I tell people at this beginning, if you ever say that can't happen, you're gone. Because once you say that, you cut out lines of investigation. And Sherlock Holmes always said, when you rule out the impossible, whatever's left, however improbable, must be the truth. So
Mhm.
you have to say, I wonder why that happened. Okay.
Yeah.
And your patient, if you listen to your patient and take a proper history, you will learn what's wrong. Okay, because they will tell you. They're not going to sit there and say, it's my liver." No, you have to listen. You have to know what the clues mean, and then you start correlating them. Testing is inaccurate in a lot of senses. Plus, think about it this way: they have a normal range, okay, which is really part of a bell curve of 100,000 tests. And if it's in the lower part, let's take hemoglobin, which is your blood, right? It goes from it goes from 12 to 16. And if you're 12.1, well, you're not anemic.
Mhm.
If you're having symptoms of anemia and you look at all the correlating findings, just maybe that's not normal for that person. That's why we call it individualized medicine or personalized medicine, which should be the forefront. So, since the pandemic, something has happened to us. And this is worldwide. I have a worldwide practice. Okay. My practice is entirely virtual. And
Mhm.
I take care of complex multifactorial illnesses that have not gotten success elsewhere. And I like to think I'm pretty good at it. Okay. Because my first visit with you is 2 hours and I will get a good history from you. Okay. And
Yes.
then I'll correlate your testing and then I'll come to a conclusion. Okay. Or at least a general way of a direction we need to go. Um, so when we talk about health and what generates health, you have to talk about the cell.
Mhm.
Remember that when you put cells together, you get tissues. When you put tissues together, you get organs. When you put organs together, you have a body. So instead of treating the thyroid or the liver or the pancreas or the IBS or the IC or whatever it happens to be, you want to look down at the dysfunction in the cells.
Yeah.
Now, in the cell, we have, if you remember the cell, teacher draw a circle on the board and you put it in a circle. That's the nucleus, that's the brain of the cell. And then you have these little open things. Those are vacuoles. That's what gets rid of the waste. And then you drew this thing that looked like a racetrack.
Mm-hmm.
That's the mitochondria. That's your powerhouse. And they go on to something else. I don't blame them because at the time they didn't know too much about it. But this is something that is critical. Your mitochondria is how everything works because it produces the energy, the gas, if you will, for the engine of your body to work at the cellular level. Now, you have 30 trillion cells in your body. To give you the enormity of how the mitochondria is important, you've got around roughly 2,000 to 100,000 mitochondria per cell, depending on how much the cell has to work. Obviously, a heart cell is going to need a lot of energy. A brain cell is going to need a lot of energy. A cell in the cartilage of your knee, not so much. Okay, so, but within those mitochondria, if you can imagine, if you could do that kind of math, okay, which I can't do off the top of my head, 30 trillion times the average of 2,000 to 100,000. Now, what is the energy really? It's like the percentage. Okay, so you're putting out, if you're sitting up looking at me, obviously you have energy. It's the relative amount. Okay.
Yeah.
So let's say you're running at 95%. That's normal. Nobody's 100%. Okay. And you get an acute illness, let's say a strep throat. That will go temporarily down to, let's say, 80%. You'll get tired, you get fatigued, your doctor gives you some antibiotics. And then at some point you turn the corner and you start getting better rapidly and you go back up to your 95%. Very often as we go along in life, we start picking up different illnesses that are sitting with us, not at a symptomatic level or at a symptomatic level, and they add up. So let's say, you've got chronic inflammation, which is giving rise to thyroid problems or this problem or that problem. It starts degrading the energy output. Let's say it gets down to about 75%, which is kind of average. The spike protein, since COVID, what that has done, and it occupies something called the ACE2 receptors. It's not important that you know the name of the receptor, okay, which is all over the body. It's dropped mitochondrial function from, let's say, that 75% to 50 or 55%, which is kind of nasty. Okay, so somebody who had no problems before may find that they got ill and never got back to their former self, okay, their former energy level. A person who's had some issues and they got much worse during the pandemic never got back to anywhere near their baseline. All the studies, there's a ton of studies that have come out, and I've got my suspicions of, and I don't want to be cynical with everybody. Since the pandemic, are identifying ubiquitously the spike protein. It's called spikeopathy. They're calling it a toxin, right? And it specifically interferes with your energy output. So you become sicker. You become less able to fight anything that comes along. And we live in a toxic environment. We have to fight. Well, right now we have the cyclosporal problem,
Yeah,
We
I
have,
saw that in the news.
right. And I'll tell you something. The cyclospora is one of those microorganisms that's around and usually in small amounts is not going to bother you. But right now, I think we have a sicker society. So we're being exposed to not so horrible amounts, but we're responding, or we have a lack of
Horribly.
response
Mm.
to
It's like
what
when
we're
your
being
immune
exposed to.
system goes down,
Right.
any radical can be a big
Exactly.
issue for you. And those are things that
Absolutely.
wouldn't concern you if you had a good buffer system. I think like
No, you're
that's
right.
science.
And you can think of it like a buffer because that's exactly what it is.
Yeah.
And if that buffer system becomes dysfunctional, you're less able to respond. Okay. You're less able to, and it's really an adaptation or compensation thing. Okay. So a lot of things go out of whack. You might get more mood problems. You might get more gut problems. You might get more, of whatever was going on before it gets worse and becomes more expressive. So the
So,
whole point of this is to say that what's happening at the cellular level is the genesis of all your symptom expression. In other words, what you're feeling, what you're seeing is coming from there. And that's the thing that almost no one treats.
thank you so much, Dr. Armin. Before we continue to get into a more deeper level for this conversation, I know that my audience are wondering, who is this? I mean, I keep calling you Dr. Armin, but
And Dr. Jess is better because the whole world calls me that. I don't know why. It started about 20 years ago. I'm like, far be it from me to argue with people.
yeah, but can you maybe in a minute kind of like give us a background of who you are?
Sure, absolutely.
If you're enjoying this conversation, don't forget to subscribe to What About Rural Health on all podcast streaming platforms. We are on Spotify, Amazon Music, Apple Podcasts, Listen Now, and so on. And yes, we are on YouTube too. Your support means a lot to us. Please like, leave a comment, share, and most importantly, give us a review. It helps others discover this important conversation.
Sure.
I've been in healthcare in one form or another for 50 years. Literally started in 1975. I know I'm older than I look, I think. I hope. Because I'm going to be 70 tomorrow morning. You know, like, ah! My mother looked at me and said, "You're going to be 70." I'm like, "Yeah." How am I? I'm like,
Well,
she's great. She's phenomenal. My mother. She's a I can't say enough about her. Okay, so I started out as an EMT and became one of the first paramedics in New York City. At the same time, I decided to become a nurse. I come from a poor Italian family where like almost no one graduated college. So I thought that was way beyond me. So I went to college for nursing, and in 1978, um, I got a bachelor's of science in nursing. I was also an ROTC, so I went into the Army, and I was an Army nurse for several years. I started out in their emergency and then became head nurse of a coronary intensive care unit. Of course, I wanted to become a doctor because those guys weren't any smarter than I was. Okay, so I had to take all those courses. I decided to become a chiropractor, and I went to chiropractic school. I took the 3.5 year course, which was three. What? Guess what? 3 semesters. Don't. That's how that happened. Don't do it. Okay. Take your vacations. Okay. It's like, okay. Anyway, I graduated in 1986, and I started practicing standard chiropractic. Also started a family. Okay, and it was okay, but to me, it was limiting. You know, the diagnosis and stuff was. I love putting the puzzle pieces together. I really do. So I had an interest in alternative medicine and traditional medicine, you know, and how they interacted. One of my children developed mental illness. And this bright, intelligent boy who read Dante's Inferno at 10 years of age and explained it to me, okay, which made me do this, you know, um, became a non-entity with the medications, you know, and frankly, I got very angry. And I'm also a Christian minister. You know, I started praying, and I just kind of looked up at the spirit of God, however you conceive, you know, the higher power. As this disease is messing with the wrong daddy. Really. So when you go on a course like that, the universe puts things in front of you to learn. You know, so you want to learn this, and I started developing expertise in neurotransmitters, and I got the first certification in a subspecialty called neuroendoimmunology, which was a relationship between the immune system, the nervous system, and the hormone system. Okay, because they constantly talk to one another, and that's the basis of homeostasis. I started, you know, learning a whole lot of things to help my son, and we started working with an integrative psychiatrist who's got to be one of the most brilliant women on the planet, and he did very well. He's now a graphic artist, okay, full time, and he's still very intelligent and very glib. I love the heck out of him. He's just sitting and talking to him is just an entertaining thing. But what ended up happening, the shift that happened was I started seeing people who had chronic illnesses that were frustrated and didn't know why. They weren't getting any answers. They got
So
lots of medications, but they didn't get any answers.
I want to ask,
Please.
because obviously, like what you just told me, and then I mean, thank you for like 50 years of service to the medical field. When I think about when we moved from having a comprehensive care where you can identify something and trace it to the whole body and can be able to address it, to now where we have different fragmentation, like you mentioned earlier on. I was just so happy, like when you were talking about and describing mitochondrial and how that functions. It seems like somebody somewhere sat down and bifurcated human body and decided that different people are just going to focus on different aspects of these places. An eye doctor and a nose doctor is literally pick on. In fact, a front tooth doctor, there's also someone that should take care of your back tooth. Like at the end of the day, I personally have difficulty accessing the healthcare system, and I live in an urban area where the healthcare, like hospitals are near me, but it just takes so much time making appointment with different people. And at the same time, you would see that the diagnoses are all connected to one singular thing. The obvious one is now, if you remember, the changing of PCOS to MCOS or something. It's trying to draw out to say, no, PCOS is not just about ovarian issues. Can we look at metabolic issues and how that is? It's because people decided to bifurcate human body. That is why we are studying different parts of people. So how did we get here where we are now struggling with medicine, Dr. Jess?
I actually saw that transition happen in the 1960s and before. We had our GP or family doctor. Okay. Now, for those of you in my age group, you remember the TV program Marcus Welby, MD. He was the quintessential family doctor, and his assistant was Dr. Kyle, the younger man who, basically trained with him. And he knew everybody. He knew everything, and he would send people out to specialists when it was necessary. And I saw this with my own GP when I was young. Dr. Siegel, he knew everything, and he also knew me, and he knew my parents and knew my grandparents. He's the guy that came to your house when, you had 103 fever and all that kind of stuff that we lamented we don't have anymore. And by virtue of that, when he would send you to a specialist, the specialist would barely talk to you and say, I'll call your doctor. Your specialist will call your doctor. Your doctor will call you and say, this is what the specialist said. This is what I think we should do. And that's what you listen to. And you had the comfort of knowing that you had an advocate, that he knew what he was talking about, and he'd never steer you wrong. The 1970s happened. I literally watched this happen, where instead of going into general practice, there was a shift towards specialties. Okay, now I'm not even going to get into the rationale of it because, So instead of being a GP, the GP got ostracized. You have to be a specialist. That's all well and good, except no one was coordinating. Yeah. So you go to an orthopedist, or you go to a internal medicine doctor, or then somebody who especially treats diabetes. And the system changed around so that you really didn't have anybody who would put the puzzle pieces together and say, this sounds more like, so if a woman comes in with belly pain, okay, is it gastrointestinal? Is it gynecological? Is it genitourinary? Is it kidney? Okay, it can be, even when I'm examining somebody, you have to take a history and do an examination, and you can at least hone it down. So they'll go to one specialist and then another and another. Just like you said, they have to call people, make appointments, and that may be better. Okay. And the onus of diagnosis is on the person least trained to do it, and that's the patient themselves. Yes, we have family doctors, but if you haven't noticed, you're lucky if you get 15 minutes, 10 minutes. It's not the doctor's fault. Medicine became corporatized. And corporations want productivity. So they force the doctors into these models where they needed to see 4 to 6 patients an hour. So they start using physician extenders, PAs, nurse practitioners. And like I said, if you get to see a nurse practitioner, you're usually doing pretty good because they have more time, okay, because they're not fee for service, okay? They have more time to deal with you. And because they mainly are women, they're more nurturing, okay? And trust me, I'm a nurse also. So in my class, there was like 3 guys, one of them being me, okay? And that's still very true now, okay? And that's fine. That's fine. Nevertheless, no one's coordinating. No one's your advocate. It's too corporatized. It's too like a corporation. And the doctors don't have a choice in the matter. You may say, oh, you should go out and you want to be this. Well, guess what? Otherwise, you get kicked out of networks. You have a family now. You have to pay, you have to pay a mortgage like anybody else. You have to pay for your cars. You have to pay for your kids. And doctors, you think, oh, they all go to private schools and stuff. Not anymore. Okay. Surgeons don't get paid big bucks. They get a case fee. Mm-hmm. That's it. You know who makes money? The anesthesiologist, because they can bill every 15 minutes. Nevertheless, the whole system is set up to not make you an entity. So if you're doing that, you're in Philadelphia, where you can't swing a dead cat and not hit a doctor, okay? Mm-hmm. We're the most medically served area in the world. You go to the rural communities, multiply those issues geometrically. I mean, it gets worse. So you don't have anybody who's putting it together. And now you have to figure it out. Then you have to, you may not have these specialties or subspecialties within arm's reach. So you can have to go to whatever the next city is and so forth and so on and so on and so on. In the meantime, you're suffering. Yeah. This is worse with mood problems. If you decide to go, for depression, you go to your doctor or your nurse, I have depression. They're going to give you an SSRI, which helps stabilize serotonin, which is the presumption is you've got a serotonin issue. And that's not always true. Judgment, yeah. Very poor judgment, okay? So they'll do that. They'll give you whatever. And then 30 days later, you come back and it's not working. So they'll double the dose. Yeah. 30 days later, it's still not working. They'll use a different one. Same thing 30 days later. About 6 months down the road, they're going to figure, maybe we should use something else that raises, instead of serotonin, dopamine and norepinephrine. Eventually, because they're guessing, okay, I lecture about this all the time because there is neurotransmitter testing. And when I'm lecturing about that, I always get this one person there with the round glasses, with the bow tie, who raises his hand, and in a nasally voice, he says, well, that's not the CNS. That's not the central nervous system. And I look at him and say, no kidding. I usually say something else, but I won't repeat it in polite company. Like it's a combination of central and the peripheral nervous system. But if you look at the pattern, you'll get an idea of what's up, what's down. So I can start better than most people. So
when you mention looking at the pattern, that takes me to bringing back the conversation around holistic care. Mm-hmm. Because what you've just described now is, we used to know medicine from a traditional point of view, where I grew up in a rural environment. We had a doctor. And this one particular doctor, like you mentioned, is who I knew until I left the community. And I will tell you that whenever I go back to the village, I mean, he's dead now, right? He's old and gone. But whenever I go back to the community and there's a remote concern about health, my mind triggers to that family physician that we have, and that was traditional care, because they knew us. You invite them for Christmas party, they come to your house because they know everything about you. But now, I mean, population is expanding, and I get urbanization, and I get globalization, and I get commercialization, and I get corporatization, and the big name that comes with it, right? And things get to move forward. Even young people are, trying to fight the old ways, thinking it is inefficient. Everybody is driving towards efficiency. Yet we have enormous problem that make us lose trust in the health system, because we want to do it the way that is anti-wealthy. anti-healthy for us.
It's anti-wellness.
Anti-wellness, yes, that's the
Exactly,
right word.
because they want to treat disease.
Yeah.
That's where the money is.
But then we are bringing back the conversation around holistic care. What I'm trying to ask here, in essence, is how do we now marry this evidence-based, health system that we've pushed ourselves to, where money leads the way, insurance is the first, knock on the door before even a doctor or even a receptionist asks you, who are you and what brought you to the hospital? They want to know what insurance quality you have. And
Exactly.
how long they're going to commit to you. I don't blame the hospital system. They are always overwhelmed and then try different models, but it's not working. So how do we bring in holistic care in a way? Because that conversation is being thrown around, and I don't like buzzwords. I like people to walk me through.
Let's use generalized terms, because holistic, personalized,
Exactly.
integrative, functional medicine. Okay, here's the thing. The traditional medical profession, it's allopathic medicine. I'm just going to call it medicine. Okay. Medicine is very far down this particular road. Okay. And I will tell you, because I teach a lot of medical doctors, and they don't want me to mention their names, but they are frustrated as heck.
Yeah.
Why? Because they're caring for people and it's not working, so they joke around saying, here comes Mrs. Smith coming up the path, shut the doors, shut the windows, let's go out the back. Not because they don't care, but because they don't know. So enter a different point of view. Now, literally holistic treatment, and again, we're going to use that for functional medicine, holistic treatment, integrated treatment, all that good stuff, okay? Holistic treatment should be, I should be picking up the looking at the whole person thing. Okay, just like the GP. Sit there and go, okay, And if I trained like I'm supposed to, I should be able to bring all my experience, listen to what has already happened, get the clues from that, get their whole story. And you can know somebody from a baby on outward if you spend a little time learning about them. Certainly not as good as the old GP, but you can approximate it. I even teach a course on that. Okay, like here's how you take a history. Not checking off things in the waiting room and handing it to somebody. Guess what? They don't read those. They read what the complaint is. That's it.
Yeah.
Okay. They don't have the time. Even if you fill out the stuff beforehand, these days it goes in electronic medical records. They look at the results of whatever it says. They look at lab work. They look at the little space that says, here's the abnormals. They don't look at the normals and don't see where it is. But again, it's a time issue. We were supposed to take over the old GP role, but since everybody wants a specialist, when I tell somebody I'm a doctor, the first words out of my mouth is, what's your specialty? Okay.
Yeah.
The general public has been trained to do that. And what happened in the alternative medicine world is everybody started specializing. I have my problems with that too. Okay. They started specializing. So who does just hormones? Who does just detox? Who just does, and they run into the same problem going down that particular rabbit hole and not looking at everything. I'm also a genetic expert. So the whole genetic craze, MTHFR and stuff like that, I know all about it. Regular medicine is 15 years behind us. Okay. And so I can look at your pathways and tell you what the possibilities are, not what's going to happen. It's not your destiny, but what the way it should be used is that, look at that pathway. Maybe I should look around where they don't look like he's going to break down histamine too well. Maybe I should add that into my head that, the histamine could be a problem. That's the way you should be looking at it, or they're not recycling glutathione or whatever it happens to be. Nevertheless, so we're guilty of the same thing. And who suffers? Our patients.
The patients. I can tell you that for free. It is the patients.
I have been fighting this uphill battle for quite a while. By the way, you should know that the concepts that I've come up with finally are getting very common in alternative medicine and making inroads in traditional medicine. Okay. Which is looking at things from the cellular or the foundational level. You'll see it like a terrain treatment or bioterrain treatment. I mean, I invented all that stuff. I was yelling at people for 20 years, and all of a sudden they're like, we discovered. Okay. I don't care if you put your own name on it. It makes no never mind to me. Just do it right, will you? Come on. Really. I don't have, I'm sure I don't have an ego when it concerns my patients. I'm sure I have an ego the size of Cincinnati, but, when it concerns this kind of stuff, I don't, because I'm like, hey, just do it right. You do it wrong, I'll show up with my friends I'm Sicilian from Brooklyn, so I'll show up with two of my friends who have no necks, Nothing at your door, Hey, what are you doing? The doc said to do it this way. You know what I'm talking about? Come on. What do we do to earn this disrespect? Things can happen, things.
Yeah. Thank you so much, Dr. Jess. And to our listeners, I want you to pause for a moment and think about this. If someone in our rural community or in your own community develop a complex chronic illness, how many doctors would they realistically have to see before getting real answers? And how much would that search cost them? While you reflect on that, let us go for a quick break.
Do you want to help drive rural health forward? We're looking for passionate volunteers to support our work, from research to storytelling to business outreaches. If you believe every community deserves care, join us. Visit the link in our bio or show notes to sign up.
So, welcome back. You are still listening to What About Rural Health with Chinasa. So, one argument people make is that when care focuses on the whole system of the body rather than isolated system, it can reduce long-term healthcare costs. And cost is very important in this conversation because this episode is about financing healthcare. And there are different ways that care is being financed, and most of them are borne by the patient. So they're always bearing cost in their mind. So from your experience, how can this holistic approach that we are talking about potentially make care more affordable, or at least save healthcare costs for rural patients?
Well, let's go back to the fact that care is fragmented and much worse for rural patients, okay? To have a practitioner, let's say a nurse practitioner or a holistic practitioner, who will take on the responsibility of putting the puzzle pieces together, connecting the dots, doing what is proper and necessary to at least get you on the right track. Okay, then you're not going to sit there with that, I mentioned belly pain, and wonder, is it my genitourinary system? Is it the gynecological system? Is it my kidneys? Is it my colon? Is it my gallbladder? Is it my pancreas? And guess what? Or is it just my stomach? Do I just have gastritis? Do I have, GERD? Or what? But if you get a practitioner to correlate your symptoms and say, okay, because everybody builds a differential diagnosis, just means it's this, or this. And then usually, and we did when we were training, like most probable, least probable, but you considered all these things. Okay. Then you cut down healthcare costs for the patient and for the insurance companies and stuff, because they're always looking to cost cut. Because now you're going down, okay, this is a gastrointestinal problem. Okay, if we're going to go specialty, go to the gastroenterologist, because they're going to know what's going on. Maybe you need a colonoscopy or an endoscopy, whatever it happens to be, to find out what the problem is. But if you don't have somebody doing that, the onus, sadly, is on you, your stomach, okay? And what do? You go to Google, Dr. Google, my nemesis, my absolute nemesis, or WebMD, basically says, you will die. Come on. WebMD says this. I said, don't listen to WebMD.
But that's an indication of a system, not to cut you off though.
Please.
That's an indication of a gap in the system that I don't think the medical field, I want to use medical, not health, because health is very broad.
Right,
the
exactly.
medical field is not taking cognizance of or living in ignorance and complaining about. Like when you go to a typical doctor, they'll tell you, while the worst thing for you to do as a patient is to go and ask Google or AI
Right.
about your symptom. But the reason why a lot of people are doing that is, one, I talked about trust. We lost trust in the medical
Absolutely.
system. That is one.
Absolutely.
Two, because you are not accessible. It takes a whole lot of effort to book an
Right.
appointment with you. Like, for instance, I use myself an example a lot. I have severe headache. Between the time that I went to my PC and when I actually got an appointment to see the pain medicine specialist in their department, I don't know how to explain the symptom again, because it was severe as at the time that I had issues. How about that we had a comprehensive system where we go to and you look at this as at the time it matters to me. So I go through that system once, twice. I'm tired of the system. I would rather ask an AI that can just tell me, okay, what are you feeling? And as at that time, I am feeling all of those symptoms
For good
enough
reason.
to describe it to the AI or to the
Right.
Google. And the Google will be like, okay, it could be this, it could be this. I mean, we know we are chatting with a bot. That is the thing that the medical space are not yet recognizing. The humans know we're chatting with a bot, but it's like that is the only option we're left, because the
Absolutely.
medical field is busy pursuing grandiose ideas and clinical innovation that puts them in the face of the earth. We don't have issues with that, but as patients, we just want to have care. So how do we address this Google business? Because it's really causing trouble.
It is causing trouble. The problem with Google or any of the search engines is that when you put a set of symptoms in, now they have AI stuff that's going to go in, but they'll tell you what it might be. Then you go into the Google pages, and now you have to fight. You have to think about who's telling you this to sell a product. Okay.
Yeah.
And that is rampant. That is rampant. So it's not only diagnosis, it's treatment. If you do this, you take care of all of that.
Yeah.
And listen, I've seen a lot of this stuff come down the pike. I could name things, especially in the alternative medicine world, because they're not under the same constraints. Okay. If you're listening to a medicine commercial, all you have to do is close your eyes and listen to what this can do to you. Okay. Not look at what they're showing you. Just close your eyes and listen to this is going to have your left toe fall out. People have died during the trials. I'm like, you're not making me take that. Okay. Sorry. So what can we do about this? It's not going to be a revolution. It's got to be an evolution. Okay. So let's say we're in a rural community that is under the traditional medicine system. We need to get in either a good holistic practitioner who practices holistic, healthcare, or a good nurse practitioner who takes on the role of the general practitioner, the old general practitioner. And let me tell you something, nurse practitioners who are trained in family medicine or pediatric medicine, they know their stuff. They know their stuff.
I agree.
Okay? Are they some of them, please excuse me, more traditionally minded versus alternative? Yeah. A lot of them, because I interact with them a lot, understand, and we'll sit there and go, okay, really, I didn't know that. And they'll listen to what, their patients, because I write reports to my patients, they give them to their practitioners. They're like, oh, okay, that makes sense. Whereas, medical doctors say, well, that can't happen. It isn't always like that. Okay. But remember, a doctor of medicine has medicine as his or her armamentarium. That's what they've learned. That's what they're very good at. That's the way they do their protocols. They have these protocols. They have these algorithms to find diagnosis, which is married up to a pharmaceutical protocol. You're not going to make them into an alternative medicine doctor. But if down the road, which actually it's happening now, we can have actual integrative medicine, which means traditional and non-traditional working together. What would happen here is somebody would see the patient primarily and then either meet or talk with the other practitioner and say, this is what I have. Here's where I think the problems are. What do you guys think? Let's do this, and this test. Gather the information. Do it for you. not you doing it. Okay, yeah, the only thing you have to do is go to the lab.
Yeah.
Okay, this is what's necessary. So the mindset has to be, let's get us, or talk to the family doctors that are there, create an acute minor illness clinic. Yeah, the bad stuff you want the pediatrician to see.
So,
Yeah.
but I do have a rider to that question, and I agree with you when you say we need to have an evolution, not revolution, right?
Not going to happen all at once.
Yes. But there is also this, would I call it a question mark, or, when you say something with a yes and maybe, right? Kind of narrative. The current US health system, at least the current US health system, and I know, other parts of the world are pushing the narrative, using other more lenient models that kind of like privileges the patients, but that's not what I see from the current US health system. Is being driven by, care financing, what, bringing us back to insurance, right? Will the current payment model system that kind of like creates incentives for how clinicians literally practice, because I don't want to do a job that I'm not paid for. Therefore, the reimbursement process kind of like dictates what drives care delivery, or at least prescription of treatment procedures that to move forward with. So how do we kind of like put this into context with this conversation to bring medicine back to a place where patients are comfortable to go and receive care? Care providers are happy to provide care based on what they are treated. If we are going by, okay, nurse practitioner model, are nurse practitioners replacing GPs? And if that is it is, what level of exposure and training can we empower them, since it's the model we are running with, to do far more jobs and understand and know the patient? Then the patient has the nurse practitioner on file as their primary care provider, and every other person as specialists, and not clinicians dictating the rule of the game and diminish. I don't know if you understand where I'm going to.
Yeah,
But it's like a whole lot of conversation about how is money moving this conversation, or
Right.
would move this conversation, but also within the care structure, coordination structure, how do we remodel things in ways with the existing structure that we currently have now, in ways that at least still puts patients first?
Okay, I think I know what you're asking.
Yeah.
Okay, so if I go far afield, just interrupt me. You will not insult me by interrupting me. Okay, I prefer it actually,
I went to
because if I'm
school where the professors are like, interrupt me all you like.
the reason for that is, if I'm going off far afield, I'm not answering your question. Okay, or I may have a perception of your question that is not exactly what you're asking, which is fine. Okay, I'm here to be of service. Simple as that. Okay, the present system is on the diagnosis and treatment end, okay, or is algorithmic in nature. So you see symptoms, and these tests show this, blah 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 blah, and then you arrive at a diagnosis, and then attached to that diagnosis, which is in the ICD-10, leads to a pharmaceutical protocol. Now, here's the problem with that. That diagnosis is not just the health practitioner's opinion. The insurance companies want to say, well, where's the evidence? Which means testing. Okay. A real good example of that is someone can have subclinical hypothyroidism, low thyroid, that doesn't show up on the tests. Okay, until it gets pretty bad. Have all the symptoms, have all the problems, fatigue, fibromyalgia, mood problems. Okay, that can be all thyroid. Guess what? Okay, if it doesn't show up on the test, the practitioner is literally not allowed to say, hey, listen, we'll talk medicine, thyroid replacement. I need to give you T3 or whatever it happens to be that they feel like you need. Okay. Okay. You're not allowed to do that. Where is it? Show me. Because it's going to get reviewed. That's the whole thing. They got a real strict review process. So you can get away with it for a while, but you're going to, if you start getting a pattern, they're going to sit there and you're putting your license in danger, which is how you feed your family. Okay.
Yeah.
So and then now the treatment is then codified. Examinations have a certain levels, okay, depending on how much face-to-face time you have and so forth and so on. And it's reimbursed on those levels, which isn't as great as you think it is. Okay. So, they may charge, with insurance. I'll use when I was a chiropractor. I could charge $1 million for chiropractic manipulation, but if the insurance company only allows 40, that's what they're going to reimburse. I'm not joking. This is exactly the way it is. And of that 40, if there's a copay, and these days the copays aren't $5 or $10 or 25, that $40 is reduced by 25 in my reimbursement check, which stimulates me to collect the 25. When it was only $5, a lot of people just didn't collect the copays because what's the big deal? But now like Medicare, they only pay a chiropractor for the manipulation and nothing else. I would just do whatever I needed to do with my patients and not charge them, even though I was legally able to do so. But it's like, it's an elderly person. What do you want from my life? Let's do what we have to do. Unfortunately, in that system, there's only so much play, so much wiggle room. Okay. Because, if you want to spend a lot of time with the patient, the highest level of examination may not actually reimburse you for the time. Okay. So you got to find the middle ground. Now, most alternative medicine people like myself, I don't take insurance. I used to, but guess what? If I'm spending 2 hours with a patient and I'm using the highest level, 99205, which is the code for it, they're going to reimburse me about $85 for 2 hours. And mind you, it's not just 2 hours. It's an hour before him putting everything together and an hour or so afterwards developing a treatment program. Okay. Guess what? I can't live on that. I mean, it's some reality too, because we're human. We have, mortgages and rent and, just like everybody else. Okay.
Yes.
And guess what? It's like, ooh, and if I'm seeing one person at a time, if I can't get reimbursed for my time, then guess what? I can't live. I can't pay the rent for my office, whatever it happens to be. So without going cash, which is tough for people that's where the whole care credit and the care financing comes in, because now there's a range, I think a lot of alternative medicine people are getting piggish. I could point them out and tell you what to look for. Okay. And I will at the end tell you what to look for, because, people look at my price and say, well, you're real reasonable. I say, yeah, but I know more than Mark Hyman or anybody else like that. It's like, guess what? But I mean, there's a middle ground. What are we going to do about that? Okay. That is ingrained. All right. That has to change over. Now, the nurse practitioner may edge a little bit more. The insurance reimbursement is not going to change anytime soon. It's usually going to get worse, especially since this present administration killed Obamacare. And now the premiums are going way, way, way up, and reimbursements go way, way, way down. It's true. It's true. And that the way the insurance companies make money is by charging premiums, but not paying claims. Okay. So if they have it down to the minute, Tylenol, the hospital will charge $10, but they'll get reimbursed 50 cents. Getting an MRI used to be a $1,500, $2,000 deal. Now you notice the MRI centers are opening from 6 a.m. to midnight. Why? Because the insurance companies are paying them $300 for an MRI, and that's a reality. They have it down to everything. They've been working on it for years. It's going to be, again, I wish I could tell you, let's do this. But the reality is people treat with their insurance, and I don't blame them.
Yeah.
If you have any insurance, okay, you're going to want to use that. So now you're limited to who you can see or who accepts your insurance.
Yeah,
Okay.
that's a whole lot of conversation.
Well,
Whole
no, it's a
segment
reality.
conversation. And then like I imagine like in most far rural places where the care is not even available, it's like I do have this insurance. I'm able to kind of like try to get this insurance, but at the end of the day, it takes me like 4 hours to get to any kind of care. But I mean, let's take a quick break. And when we come back, we talk a little bit more about this model because I'm very interested in seeing how holistic care can come back to medicine. Do you want to help drive rural health forward? We are looking for passionate volunteers to support our work, from research to storytelling to outreach. If you believe every community deserves care, join us. Visit the link in our bio or show notes to sign up. Welcome back. You are still listening to What About Rural Health with Chinasa Imo, and I am sitting down here with Dr. Jess Armine discussing holistic care and how that can reduce costs for rural communities. So, Dr. Jess, let's say that we dive into this model that we've been mentioning for a very long time. How do other forms of system, this is specifically for my rural health, for my rural community people, how do we realistically implement it in the rural communities, not in urban area, in rural communities, but how do we integrate different kinds of care in ways that support care providers, whether nurse practitioners who are often, like I've heard about flying nurse who go to rural communities, stay a couple of weeks and come back and rotate just so care continuously being made available to those communities. I've also had other kinds of encouraging model that bring care closer to those communities, even though they are not comprehensive and situated. So how do we integrate things like telehealth, practitioners network, and any kind of network that brings care more integrated for our rural communities?
In the rural communities, the biggest problem is transportation and availability and transportation. Okay, so there are several strategies that are, and you mentioned some of them. A local integrated clinic, which is holistic and traditional medicine together, and that is usually not too difficult to put, like a nurse practitioner and a naturopath or a chiropractor together, who's trained in functional medicine. Those kind of collaborative efforts usually take care of a lot of the basic work. Telemedicine works very well because you can have access to these ultra specialists, right there, either by they have this little robot walks around, talks to people, and I always find that pretty cool because walking around, you see the screen. But, either the specialist can talk with someone or you can consult with the specialist. Okay. Those kind of collaborative networks work and really save an awful lot of money on both ends, because telemedicine doesn't necessarily need to cost as much as, somebody in telemedicine. I can speak to somebody for 15 minutes and go right on to the next and the next and the next, as opposed to, and I can have AI take the notes for me and so forth and so on. I mean, it's very efficient. And what I'm doing is allowing my time, the people who consult with me, get my expertise, as opposed to having to do all the scut work around it. Yes, you have to check it and have to read it and so forth, but they're doing all that stuff. Those kind of practitioner networks, in my estimation, work very well. From my point of view, as an instructor, targeted education, I have traveled around the world to teach, but something, since the pandemic, everybody got used to telemedicine. Okay, I was already set up for it beforehand, but training is essential. And now I can teach courses and take courses, like especially new one. I just did a course on the mitochondria for 2 weeks running. Learned a lot of stuff that I thought I knew, but I didn't. I was like, ooh, okay. But it was minimal cost and was a little bit of my time. Guess what? And I didn't have to travel there and back and forth. Or if I'm teaching, I can teach from right here where I'm speaking with you, still get my point across and still have everybody understand it. And they're not sitting there scribbling. They get the slides, they get everything else. And it adds to their ability to treat people. If we could set up as a minimum traditional and non-traditional medicine, a nurse practitioner, let's say a chiropractor or a naturopath. Naturopaths are phenomenal also. And they go, they go to as much school as I do, together, who are willing to cooperate. And that's not a given. That's you can almost count on that. Or even a family doctor who wants to interact. That'd be a good first step. Okay. Because they may charge, I don't know how that gets charged, but they would charge the insurance. Okay, whatever, I'm sure there's some kind of consultation fee or whatever. I never got into that. And it might be usable. But what we see now are concierge practices where they'll take your insurance, but they charge you $1,200 a year to have better access to the doctor. But guess what the doctor does? One of my friends did this, had to basically let go 3/4 of his staff. And, he hey, I could call him up and get an appointment the next day or that day, and he with himself would get on the phone with me, Jess, what's going on? But for him, he had to essentially fire a bunch of nurses, to keep his costs down so that he could have more access. That's a stopgap measure I'm beginning to see. Okay. Once you put these two professions together and make it work, you're going to see that it's less costly, more accessibility, okay, because you're not going to have to travel all over the place. And, when it becomes a successful model, people want to repeat it. People want to duplicate it. Okay, yes. So once that starts happening, then that 2-week wait becomes a 1-week wait, becomes a 3-day wait, becomes we can see you at 3:00, that kind of thing. All right.
If we get to that point, well,
it's got to start somewhere.
Yeah. And that somewhere is where I want to take this question too, because you've spent time teaching other physicians, and I know a couple of young medical professionals who are tired of the current system and are exploring new ways of, working together or just learning how to make care more integrated. So if you want to see this kind of holistic integrated care expand, like you mentioned, you keep expanding, what role will physician training play? What would we need to change in how these physicians or clinicians are trained or supported? So the first thing is, what role would the training, do? But what do we need to change within the current training structure that would then support this kind of training to happen and for clinicians to be supported?
The best type of training to have is functional medicine training. I've taught a course like that myself. I'm creating another lengthy course. There are good courses out there for physician level or healthcare level people, doctors, nurses, naturopaths, and so forth. And what they're learning there is how to coordinate. And when I teach that course, the very first thing I talk is I don't want anybody to feel that what they do is not important. So I usually let them know that, gee, you're going to hear things that may go against the grain for you, but I'm always being respectful and treat it as information, and we'll correlate it together. Okay, so when in the conduct of the course, when you're treating ADD or ADHD or something like that, and you're treating it from the outside, let's try some Adderall, let's do this. And I teach you that, if the Adderall works, it means they don't have enough norepinephrine, because that's what you're kicking. It's adrenaline. That's what you're kicking the body to do. But if it doesn't, maybe the reason they have this problem is because they have so much inflammation in their brain that they have the attention span of a gnat. Okay. That one phrase showing that there's two basic reasons for attention deficit disorder changes the entire way the traditional medicine person looks at the condition. I can speak from both ends. I don't have a soapbox to be on where I'm going to say you must treat this. Yeah, that in later when it makes sense. Okay. Repeated stuff like that, looking at the genetic pathways and how things recycle and how, what's necessary to have those pathways work correctly, and all the different things go about it, like, absorbable vitamins and minerals and yada, yada, yada. Okay. That adds to their paradigm. And when you explain it in language that they can understand and you can support it, it becomes part of the way they treat. And yes, they're always looking for protocols. Fine. But what do I teach them about protocols? That protocols are a jumping off point, not an end unto themselves. That gives them, believe it or not, the freedom to do it because they've been told, if you trust me, those pharmaceutical protocols, if you do not follow them, they are called standards of care. And if you don't perform, if you go outside the standard of care, you are committing malpractice.
Yeah.
That's why they do it. But to have the freedom of the wiggle room to understand, maybe I can follow that protocol. Maybe I should include this pre-work so that the cells actually work, so they'll respond to that. It's all a matter of point of view. So functional medicine courses, good ones, will take the medical model with the idea of, okay, let's add this to your practices, because that's what most want to do. They don't want to change over to be alternative. They want to add it to their practice because they have those patients they don't know what to do with, and they are frustrated.
Thank you so much, Dr. Jess. I would ask you this one final question.
Sure.
So, this change will not just happen by super training clinicians and medical practitioners. There is a policy component to it. And I think that is where most change comes from, because when you rewrite the policies, it's easy to restandardize the boundaries of care. So if you get up from, this conversation with me, and as you're walking out, you meet a policymaker or someone who is a specialist in helping design how health systems work, and you tell this person, hey, see, we know there's a problem. That is obvious. We've over talked about it, but let's look at, redesigning the solutions for health systems. And if we are serious about this, here's a model that I think can work. But how about we test this kind of care model in rural communities and see what comes out? What would you recommend for this person when he says, yeah, you convinced me, I'm fully bought in? What would you recommend to this person for us to start doing first?
They already have the stats on what healthcare costs now. It's not a secret, but they have to look at people, how much they're spending and how much the patient's spending and compliance and so forth. And they need to be willing to do trials of, okay, let's see if we do this and set up a clinic with telemedicine. They already know how much telemedicine saves them. You don't have to convince them. Okay, they already know how much they have to pay a nurse practitioner. They're worried about alternative medicine because they feel like they're going to have to pay a lot of money. But guess what? If they can put it together and show, and they will, that the combination of these things lowers the healthcare cost, and they could do this in less than a year, lowers, because it's going to be significant, lowers the overall healthcare cost and patient satisfaction. They're always saying, oh, we have the best satisfaction. I remember one insurance company saying, we have the lowest disenrollment rate. People are leaving, but they're not leaving in droves like everybody else, right? Okay, I love the way advertising works. Nevertheless, if you show them that they always want to save money, but if you show them that not only will they save money in this model, but the patient's going to be a whole lot happier, and they're going to stick with you, Blue Cross, as opposed to Aetna, as opposed to whatever it happens to be, because that's how they make their money. They sign people up. Guess what? They'll sit there and go, ooh, I saw this happen with a particular test called Approve, PROOVE, where it was doing genetic testing on people to predict what pain medicines work better for them. And the pain medicine doctors were utilizing this, and they had less addiction, better outcomes, because it told them, okay, this one for this person, this will work better for this and this has to do with the detoxification pathways. And within a year or two, the insurance company said, well, we're going to cover the test, and then we're going to require the tests because it was better patient care, better patient compliance, okay? And people were getting out of pain quicker. They were getting back to work quicker, okay? And all that somebody had just had to be put on notice, okay? This model will work. It's just going to take some time. Somebody's got to pick up the gauntlet. Some business type who's a visionary that can sit there and say, hey, this is how we can set this up. The worst I could say is no. Okay.
Yeah, that's true.
It will benefit so many other people, seriously.
Thank you so much, Dr. Jess Armine.
Thank you for having me. I really
for
appreciate
being
it.
here today. It's really a thoughtful conversation for me, especially, talking about all of these things together. It's like we obviously know there's a problem, but we are all looking for a model that could potentially be more impactful than what we currently have. And I appreciate the fact that you take your time to explain all of these in the ways that it borders around affordability, access, but most importantly, dignified care for patients who
absolutely
are looking for care.
I do have one thing I want to leave for everybody. Okay, I promise to tell you what to look for alternative medicine practitioners, and I don't want to go back on my promise. All right, the biggest issue and the biggest concern about seeing somebody like myself is the cost.
Yes.
Okay. Normally, I will do my entire intake before I consider doing testing or anything else like that. I'll review everything. But there's a whole set of people who will require you to do what they call onboard testing, which is a bunch of testing, usually a couple of $1,000s worth. And then when it comes back, they'll make you wait until it all comes back, usually about 6 weeks, where you're sitting there real anxious. And they'll say, okay, we're going to start working with you now. And then at the end of it, you're going to be spending an awful lot of money on supplements and so forth. That is not good healthcare practice. That's called practice management. In other words, I'm going to make you do something, and I'm going to make you want it. And then I'm going to do it. I'm going to upsell everything. They're taught to do this. So your first indicator is, if that's what's going on, find somebody else. Find somebody else. If it's not me, find somebody else, because they're not interested in you getting better. They're interested in the bottom line.
Thank you for that tip. That's a very helpful tip, Dr. Jess. And to everyone listening, thank you for joining us on today's episode of What About Rural Health. If today's episode moved you, challenged you, or made you think a little differently, please follow, subscribe, and leave us a review on your favorite podcast platform. And as always, we will continue to ask the question, what about rural health? Until next time, I am still your host, Chinasa Imo. Bye for now.